Welcome to Exploring the Brain. I'm Dr. Brad Schlager, pediatric neurologist and president and CEO of Kennedy Krieger Institute and professor of neurology and pediatrics at the Johns Hopkins University School of Medicine. At Kennedy Krieger, I have the privilege of leading a team of more than 3,000 dedicated, mission-driven staff members who, together, make it possible to provide care and education for nearly 30,000 unique patients and students each year. Because this might be the first introduction to Kennedy Krieger for some of you, let me provide a bit of information about our nonprofit organization. We're nearly 90 years old, based in Maryland, with our primary campus here in Baltimore, but with multiple sites located throughout Central and now Southern Maryland as well. And while we may be best known for our clinical services and research, we also have 5 schools that serve publicly funded students who are referred to us by local school systems from throughout Maryland and DC, and these are students whose needs are not fully met by the local school system. So as an organization, we understand that for children and teens, especially those with disorders and disabilities related to the developing nervous system, clinical care and education are inextricably connected. So thank you so much for joining us for this evening's Exploring the Brain webinar on navigating ADHD strategies for success. Attention deficit hyperactivity disorder, ADHD, is a well-studied neurodevelopmental disorder common among children and adolescents. And we have an expert panel here with us tonight to discuss this important topic. But first, a few housekeeping notes. So your video and audio will be muted during this webinar. So please use the Q&A features if you have questions that you'd like to ask. The Q&A feature is likely located at the top of your Zoom window. So you can click and then submit a question, and we'll try our best to get to all the questions during the Q&A period that's at the end of the panel discussion. This webinar is being recorded, but your identity won't be shown on the screen, nor will we identify who asks any of our Q&A questions. The planned panel discussion, we think about 50 minutes with a 20-minute give or take question and discussion time at the end. So now, I'm very pleased to introduce our expert panel, 4 of my exceptional colleagues at Kennedy Krieger, and they are Dr. Mary Leppert, a neurodevelopmental pediatrician in the Department of Neurology and Developmental Medicine at Kennedy Krieger Institute. Dr. Leppert is an associate professor of pediatrics at the Johns Hopkins University School of Medicine. Dr. Jody Lindsay, a neurodevelopmental disability specialist, directs the Center for Development and Learning at Kennedy Krieger Institute. She's also the co-director of Kennedy Krieger's Neurology and Neurogenetics Clinics. Dr. Lindsay is an assistant professor in the Department of Neurology at the Johns Hopkins University School of Medicine. Dr. Rajneesh Mahajan is both a pediatric and an adult psychiatrist at the Center for Autism Services Science Innovation at Kennedy Krieger. He's also an assistant professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine. And Carrie Rush. Dr. Carrie Rush is a psychologist in the Center for Neurodevelopmental and Imaging Research and the Center for Neuropsychological and Psychological Assessment at Kennedy Krieger. She's also an associate professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine. So welcome, Mary, Jody, Raj, and Carrie. And so let's get started. Jody, let's start with some basics. What is attention deficit hyperactivity disorder, ADHD, and how common is it?
Sure, Brad. Well, as you mentioned in the introduction, ADHD, or attention deficit hyperactivity disorder, is a neurodevelopmental disability or disorder that often presents in childhood, can be ranged from anywhere in early childhood, but often can present with symptoms even into adulthood. It's a disorder where we see a number of symptoms that include difficulties with focus and attention, but also at times in some individuals, increased activity levels and impulse control. It is one of our most common neurodevelopmental disabilities. In fact, looking at some of the numbers, it occurs in about 1 in 9 children ranging from the age of 3 to 17 years of age. And we see rates almost 2.5% to 3% in adults as well. Of those individuals diagnosed in childhood, about 50% of them will still have symptoms present into adulthood.
So Jody, sticking with you, what would you say are the most typical signs and symptoms when children present with ADHD?
Sure. So We often look at those symptoms in those two categories that I mentioned initially. So, those that focus around attention and focus. And so, some of those can look like easy distractibility, depending on different environments, difficulty attending to a certain task or piece of work in school, or even in our children of younger age, their ability to attend to a play activity that we may see. We certainly can see difficulties following instructions, particularly those that may contain multiple steps, difficulties with organization of tasks and procedures, as well as daily routines can be affected as well, as simple as your morning routine of getting ready and out the door for school, or your bedtime routine of brushing your teeth and getting changed into your PJs can be things that we see affected. When there are symptoms related to increased activity levels or impulse control, we may see difficulty staying seated, difficulty waiting your turn, difficulty not blurting out an answer, or sometimes some excessive talking. We may see individuals who may be described as constant motor or on the go. We may see some activities where more frequent climbing or lack of awareness in their environmental space, as well as the impulse control of that kind of thinking or doing something or saying something before you can kind of catch yourself in it, can be difficult. And most of these symptoms surround our ability with executive functioning, and as that develops through childhood and into early adulthood.
So really a variety of ways that ADHD can show up. So Mary, let's talk about how you corral it into a diagnosis. What is the process for making an ADHD diagnosis?
Well, thanks, Brad. Like, all things in medicine, I think we approach everything first with a history and a physical examination of child. And we do that because there are really five criteria for making a diagnosis. And those five criteria include the fact that the behavior that the child's exhibiting has to be developmentally inappropriate for their age or their ability level, that the symptoms have to be present for 6 months or more, that they have to occur in several settings that the child's engaged in, so school and home or extracurricular activities. And I think most importantly, these symptoms have to be functionally impairing. And the history will help us with whether or not the behavior is developmentally appropriate or whether it's present for more than 6 months. The physical exam combined with the history really helps us with the fifth criteria, which is making sure that the diagnosis that there's no physical, mental health, emotional, or environmental things that are contributing to or mimicking symptoms of ADHD. So once we get through that in the history and the physical examination, if there are things that we're suspicious about, physical, mental health, academic, things that may be mimicking the symptoms, we pursue those. But if not, then we go ahead and really what we use standardly is measures of rating scales for behavior. And we try to get those rating scales completed by people in the different environments that the children live, play, or learn in. And those help us determine the other criteria, which is the severity of the symptoms as to whether or not they're functionally impairing for the child, and also whether they're occurring in several environments.
Raj, one of the points Mary made there was around the developmental appropriateness of behavior. So it raises the question of how ADHD symptoms might present differently at different ages. What would you say about that?
Thank you, Brad. So by definition, ADHD is considered to be a neurodevelopmental disorder. And what that means is that the symptoms change with age. And as the child grows older, the way the symptoms manifest might be different. frequently, as Mary said, you have to determine whether the behavior that is occurring is beyond what would be expected for a particular age, especially in younger children who, in toddlers, for example, some of the behaviors may be typical or normal, but as the child grows older, other symptoms may emerge. So the two main categories of symptoms that we typically use to determine ADHD is one is inattention, and the second is hyperactivity and impulsivity. Hyperactivity and impulsivity go hand in hand. And usually, what we see is that younger children may present with increased hyperactivity and impulsivity. Inattention may not be as apparent in younger age groups. But as the child grows older, as they reach school age, or even in kindergarten, sometimes when they begin to interact with other children and peers, some of these, the hyperactivity, impulsivity, as well as inattention, they become more noticeable. They come to the attention of teachers or parents when they are compared to their peers. And by second or third grade, inattention may become more salient and more noticeable by the parents and teachers when the child is expected to sit still, be able to sustain attention, focus on classwork, etc. And as the child grows further, in school age children, frequently, there might be a combined presentation where all three categories of symptoms may be prominent. But what studies have shown is that there is a significant brain development around 11 to 12 years of age. There's a spurt in maturation of the brain. And so we begin to see some improvement in some of the symptoms, especially hyperactivity and impulsivity symptoms that tend to improve first. And as the child becomes a teenager, we may see further improvement in hyperactivity and impulsivity. But inattention may persist as the demands increase, as expectations are different for a teenager. If kids who are in middle school and as they go to high school, the academic demands may increase, expectations change. So inattention, executive functioning problems, etc., all that can worsen sometimes. And by 18 years of age, as Jody had mentioned, about 50% of children actually show improvement in attention also. So they may not meet the criteria for ADHD, but the rest of the children or young adolescents and young adults, they can continue to exhibit symptoms of ADHD, especially inattention and executive functioning problems as they become adults.
Got it. So Jody, let's transition to talking about treatment for ADHD, and let's begin with the non-pharmacological or non-medication approaches. What are the options that we have in that space?
No, that's great. So primarily non-pharmacological treatments are kind of the baseline for any individual with ADHD, no matter what the age is. However, when we're addressing preschool age ADHD, it should be our first line treatment ahead of any pharmacologic. And typically the recommendation by the American Academy of Pediatrics is that the behavioral therapy, particularly parent-based training behavioral therapy, is the first recommendation in treatment. Now, there are sometimes some difficulties whether that's implemented and it alone isn't successful, or the services aren't available. As we know, it can be difficult getting those resources in some areas and places in the country due to staffing and availability, or the child is having behaviors or difficulties, particularly with the hyperactivity, impulsivity, that are either safety concerns to themselves or to others. And in that consideration is when we start to think adjunct treatment with that. So primarily our non-pharmacologic treatment in that young preschool age is parent-based training models. And particularly various therapies such as parent-child interaction therapy or PCIT is one of those options. Other things that we often think about in the non-pharmacologic, or as individuals get older and develop more of those executive functioning skills that Raj mentioned, we can start to implement direct behavior therapy with that individual themselves. And that's when we can start to bring in things like cognitive behavioral therapy or DBT, where those individuals are learning skills to use to help cope with those difficulties and pick up various executive functioning mechanisms to assist with that. There are executive functioning coaches that are also available that use a lot of these techniques. And often those things are being embedded even in the services if they're interacting with other therapists, such as occupational therapists in the outpatient world or in school that are being implemented. A lot of the behavioral interventions that we're also using include those accommodations that we're attempting to provide in the school environment for these individuals, whether young school age up through even into college at times with those. And I think we'll have a discussion more extensively about those coming up. Certainly, we also use other things such as social supports, assistive technology, which could be as simple as in a younger individual as a timer and what we're using to assist, as well as then looking, as Mary mentioned, that we're optimizing everything else that we know can affect these behavioral symptoms and learning and attention. So thinking about diet, sleep, the environment that you're in, whether that be when you're in your home play area or where you're setting up to do your homework or what the classroom setting looks like. So those are all considered within the realm of what we think about in non-pharmacologic treatment of ADHD.
So Mary, non-pharmacological approaches are foundational for treatment, but it's not uncommon to start to have the conversation with parents around the topic of medication. So how does a parent, what's the process for a parent deciding whether medication in conversation with the physician should be given to their child?
That's a great question, and you started with the right framework, and that is, it is a conversation. It really is shared decision making with the family and with the physician. But I think that the most basic principle for considering medication is that the symptoms truly have to be functionally impairing. In young children, as Jody said, as Dr. Lindsay said, we consider medication, and we do consider medication right away if there's true safety concerns about the child or the people that surround that child. But otherwise, it's really parent behavior management training in early childhood. In school-age children, I think functionally impairing takes, just grows a little bit. So we, of course, think about safety in school-age children, but if a child's symptoms are sufficient to impair their capacity to learn to their potential, it is functionally impairing. Or if a child's impulsivity and hyperactivity are such that they really affect a child's capacity to socialize appropriately, it is also functionally impairing. So I really think safety first, and then in the older children, the conversation surrounds impairment, and that impairment is either academic, learning, language, or social skills.
Raj, let's talk about the types of medications, the different types of medications, and how do you choose a particular class of medication and an approach?
So there are broadly speaking, two types of medications that are used to treat ADHD symptoms. One are the stimulant medications, and the second are non-stimulant medications. Stimulant medications are medicines like methylphenidate or Ritalin, and there's another family called amphetamines. And there are several medications in each family. The non-stimulant medications, there are medications that are called alpha agonist medications, and there are two medications in this category. One is clonidine, and the second is guanfacine. There are some other non-stimulant medications. One is atomoxetine, and a recent one called viloxazine. In older teenagers and adults, sometimes an antidepressant medication called Wellbutrin or bupropion is also used. So the decision to try a medication depends upon the age of the child, depends upon what medications have been tried before. If any child has not taken any medications, then typically, according to the current recommendations, stimulant medications are considered to be the first choice because they target all three categories of symptoms, i.e., inattention, hyperactivity, as well as impulsivity. So usually, we start with stimulant medications, but there are situations where we may choose not to start with stimulant medications and may want to start with the non-stimulant medications. So usually, most of the stimulant medications, the FDA approval is for ages 6 years and older, although Adderall and Dexed or mixed amphetamine salts and dextroamphetamine, they have been approved for children 3 years and older. As as Mary said, it also depends upon how impairing the symptoms are. So we don't just rush to prescribe medications to children, but try behavioral approaches or parent training. But if all those have been tried, or if there are safety concerns, or if these symptoms are causing a significant impairment at school or at home, and the child is unmanageable, in that situation, we may start with medications first. And usually, we start with methylphenidate, especially in children 6 years and older, just because it's been around for a long time and it's been well studied for a long time in children. But one can also choose to start with the amphetamine family of medications. Clonidine and guanfacine, they don't help with inattention, but they help with hyperactivity and impulsivity. So I would start children with guanfacine or clonidine, and both have extended release preparation. So I may start with them before stimulant medications occasionally if the child has intense hyperactivity and impulsivity, or if they also have other co-occurring problems, such as anxiety disorders. And then add a stimulant medication if needed, if the symptoms are not managed by just the alpha agonist medications.
So Raj, there's this balance that we always have to strike between the effects that we're shooting for with medication and the potential side effects. So let's talk broadly about the kinds of side effects we need to take into account with both classes of medications mentioned.
So broadly speaking, all medications, all psychotropic medications have side effects. The good thing is we know about those side effects, so we often have a discussion with parents about these side effects before we start any medication. With stimulant medications, there are some common side effects such as reduced appetite. There might be increase in irritability sometimes, or they may have an effect on the sleep patterns of the child. So usually it's difficulty falling asleep. There are some situations where these medications, they may unmask tics. So any child who may have either pre-existing tics or they may be vulnerable to developing tics due to other developmental concerns. these medications, stimulant medications, can unmask tics. Um, we also talk about any family history of any heart problems, or if the child has any personal history of heart problems, or any congenital heart disease, etc. So all that is done before we start medications. The other medications, alpha agonist medications, clonidine and guanfacine, they were originally used to manage blood pressure in adults, but the extended release versions, they are FDA approved for treatment of hyperactivity and impulsivity. So we may ask the parents to have the blood pressure monitored in the beginning when we start the medication. But usually that is not a problem in the recommended doses.
Raj, you also mentioned previously about co-occurring conditions, or we often refer to them as comorbidities that happen with ADHD. You mentioned anxiety, for example. What are some of the other, and tic disorders also track along with ADHD, like Tourette syndrome, for example. What are some of the other comorbidities that track along with ADHD?
So usually we see perhaps the most common one are the disruptive behaviors. So when we say disruptive behaviors, we are referring to oppositional defiant disorder and conduct disorder. These are the two disruptive behaviors. So these are very common. And other co-occurring conditions may be anxiety disorders. Sometimes we also see other mood disorders such as depression and a new condition called disruptive mood dysregulation disorder. But tic disorders such as Tourette syndrome, um, uh, obsessive compulsive disorder, all these can be seen in children. They can co-occur in children who have ADHD.
Yeah,
I'm going to piggyback on Raj, if I may.
absolutely.
So Raj is a psychiatrist. I'm a developmental pediatrician, and I will say that in my world, the language disorders, developmental language disorders, very high rates of ADHD. Autism spectrum disorder has an exceedingly high rate of ADHD co-occurring. And I think the one that we are always on the lookout for in the school-age children are learning disabilities. And math, English, written expression, all learning disabilities carry a higher incidence of ADHD co-occurring.
Thanks.
Thanks, Mary. And so sticking with you, let's talk about other aspects of the way ADHD shows up in boys and in girls. Is it true that there's a difference in the way boys and girls demonstrate ADHD behaviors and signs and symptoms?
Well, I would have answered that question a lot differently a decade ago, but the literature is really changing. So what we know is that historically we've thought that boys had ADHD about 2 or 3 times more frequently than we diagnosed it in girls. And that seems to be true in early childhood, particularly when the reporter are the teachers. So hyperactivity, impulsivity, those externalizing features are more common to boys, especially young boys, where young girls tend to manifest more inattention and those internalizing behaviors that are really easy to overlook. But what's interesting is that as we go across school age, as children get older, the gap between boy and girl diagnoses seems to close. And that's probably because some of the things we talked about earlier, the demands as you go up in academics for sustained attention really get challenged. And that's where girls are diagnosed more often. And what we know now in adult literature is that new diagnoses of ADHD in adults are as common in women and men. So that's all a changing landscape. And it's been a very interesting one to watch, I think. Agreed.
So Mary, also, if a parent is noticing symptoms in their child, and I imagine people on this webinar might be thinking along these lines, at what age should you get your child evaluated for ADHD? And is it ever too early to start thinking about that possibility?
I I really would have to say it's never too early. I think that I will add the caveat that if there's an acute change in behavior in a child that is short-lived and very noticeable, it would be really prudent to talk to your pediatrician and make sure there's nothing contributing to that, as we talked about earlier. But, you know, a quarter to a third of children, school-age children diagnosed with ADHD get that diagnosis in the preschool years. And so, you know, if you're concerned about symptoms that may be ADHD or ADHD-like, it's never too early, because in the preschool years, really the approach is parent behavior management training. And parent behavior management training is used to both treat behaviors and prevent behaviors. And it really improves the dynamic between the child and the parent, whether it's ADHD or other causes of disruptive behavior. And I think that confers sort of short and long-term benefits for the child and for the family.
And if I can jump in for just a second. So just to add to what you said, you know, any kind of deviation from development, normal development, or if your parents have any kind of concern about the development, you know, they should talk to the pediatrician and seek any further help. And like you said, you know, I think I work mainly with children with autism spectrum disorders, and frequently they both ADHD and autism co-occur, and you want to have as early a diagnosis as possible, so that you can intervene early and get the help that the child needs, because that can have an impact on the developmental trajectory of the child.
Yeah, excellent point. Thank you, Raj. Jody, let's talk about teens and adolescents. How does ADHD impact, for teens and adolescents in particular, activities outside of school, their social lives, preparation for college, transitions to independence? What would you say?
Yeah, I think it starts with the increasing demand that's put on individuals as you're starting to develop through adolescence and the high school, and how you juggle different activities, knowing that you have these things in school to organize versus your sports and other extracurricular activities. But also those things demand your focus and attention and organizational skills and those as well. So what strategies can they learn to carry across to assist in those areas? The other big piece that we haven't talked a lot about today is the difficulty with emotional regulation that we can see in individuals with ADHD. And it's not one of those kind of core symptoms that we necessarily talk about in our diagnostic criteria, but it's something that's very well known and affects nearly 70% of individuals with ADHD to some level. And so these things start to become more prominent in those adolescent years and teenage years, where we know your ability to deal with those social interactions and emotions can be difficult. And so some of the things that we can see in these individuals is sometimes difficulty with lower resilience, inability to kind of restore an emotional balance when something becomes upset, having kind of a deeper focus when conflicts do occur, which we know occur much more often again in that middle school era. And then we tend to see sometimes some more persistent negative emotions or kind of negative self-talk, right? Of how they feel with their self-confidence and esteem in relation to these symptoms and difficulties. And then thinking out towards college, like you mentioned, really starting to think about how we're building those independent skills and how we're able to get through those daily schedules and plan for long-term projects or long-term events. And how do we really start to help assist with those type of executive functioning skills? The other thing that I'll mention too that we don't talk a lot about and that requires a lot of these skills is when we start to think about teenagers driving. So how symptoms of ADHD can affect our young drivers as well. And so that's something I really try and talk to my young adult patients and teenagers about, as well as with their families.
So Carrie, I think it's time, we need some expertise in psychology here. in this discussion. So let's talk about the difference between a school evaluation with academic focus and a private evaluation. What do we mean by those distinctions there?
All right, thank you, Brad. Yeah, this is a question I'm often asked while providing psychological assessment services in our clinic here at Kennedy Krieger. So the goals of these evaluations are often different, as are the qualifications of the professionals who are conducting them. So a school-based evaluation is typically done by a school psychologist. It focuses really on understanding how the behaviors or symptoms of ADHD might be impacting learning or classroom functioning. And this is towards the goal of informing educational planning. Whereas a private evaluation is typically done by a medical or mental health professional and will be focused on determining whether a child meets diagnostic criteria for ADHD based on symptoms occurring across home and school settings and really causing impairment in functioning. And this is needed to inform the therapeutic planning and what sort of therapies are indicated. But these evaluations might include some of the same tests and measures. So often I appreciate when a school evaluation has been done so I can look at that testing to either save some time in my own test battery or just to understand what the school's focus was. And so in terms of those tests and measures, the school evaluation will often include parent and teacher rating scales of ADHD symptoms, but a diagnostic clinical interview will not be conducted, which includes a detailed medical and developmental history, questions to understand the context for ADHD symptom expression. So without that information, a formal diagnosis of ADHD is typically not provided. Instead, the school evaluation might include a classroom observation to inform the type of behavioral supports that may be helpful. If there's concerns for learning, the school evaluation may also include cognitive testing, such as an IQ test or standardized academic or language testing to determine whether the child might have an intellectual disability or learning or language disorders. In contrast, a private evaluation would include a diagnostic interview, really that's central to it, to determine if a diagnosis of ADHD is indicated, and really a careful review of the child's medical and developmental history and existing records to understand some of the other factors that could be contributing to their current difficulties that need to be ruled out before a diagnosis of ADHD is provided. It may also include cognitive and academic tests to determine whether other diagnoses might be indicated. And in addition, it often will include assessment of the child's mood, social functioning, language, memory, and attention or executive function skills to understand other factors that might contribute to ADHD symptom expression, and again, to inform therapeutic planning.
One of the most important spaces to consider for a child with ADHD is in the school setting. Often a child with that diagnosis will qualify for an individualized education program. How does a parent best navigate making sure that their child is getting the support that they need and deserve through the IEP, through meetings with teachers, and so on?
Yeah, it's a great question. And as we know, like school is a child's job, right? This is a really important part of their life where they're spending a lot of their time. So in my experience, it's usually best to start by talking with the child's teacher about your concerns, whether it's behavior at home or difficulties with schoolwork, to understand if these things are also happening in the classroom. The teacher's perspective is often an important part of an ADHD evaluation, given that the diagnosis requires symptoms are present across settings and informants. It's also helpful to hear what types of supports the teacher's already been providing or would maybe recommend for your child. To prepare for that conversation, it's really helpful to document information that's come home from school regarding their behavior, poor grades, incomplete work, some of the things that you have a sense the teacher is seeing at school. After meeting with the teacher, you often would want to pursue an evaluation with a psychologist or medical professional who specializes in ADHD diagnosis if you don't already have that documentation. And then sharing that diagnostic report with the school to request a meeting to discuss setting up a 504 plan or an IEP. I realize not everyone may be familiar with these terms, so I'll briefly describe them and their differences. So a 504 plan and an IEP, or individualized education program, these are legal documents associated with special services and accommodations for children with disabilities in educational settings. So an IEP is a detailed document outlining services, accommodations, special education, and goals for the student, and it requires ongoing monitoring of progress towards those goals. A child diagnosed with ADHD only without co-occurring learning disabilities, for example, often may not qualify for services under an IEP as the criteria are a bit more stringent, unless the severity of ADHD symptoms really cause major impairments and they're not able to access grade level curriculum. However, a child with ADHD would likely at least qualify for a 504 plan. For a 504 plan, your child must have a disability that substantially limits one or more major life activities, which includes learning. So the 504 plan is typically less formal than an IEP. It doesn't include these defined goals or progress monitoring towards the goals. If a student it comes down to if a student needs accommodations only in a regular classroom, they will generally get a 504 plan. If the student needs special education services that go beyond general education instruction, then they'd likely qualify for an IEP.
You mentioned accommodations there. What are accommodations, and what kind of accommodation does a child with ADHD get in school typically?
Yes, this is a big part of our assessment services that families are saying, my child needs help. Please tell the teachers what to do. And I always say I will recommend lots of things. So if we ask for 20, I hope we get 10. But we do recommend lots of supports and accommodations. So this is really how can we accommodate this child's disability to make them more successful or able to achieve their potential in the classroom. So these fall into different categories. But if we think about supporting and managing behaviors associated with ADHD in the classroom, some of the most common accommodations that I recommend and that are often acceptable to the teacher will include things like extended time on tests and assignments, having prompts or cues from the teacher, gentle prompts or cues, not sort of calling them out in front of everyone, but just keeping them on task to help keep the student focused, having preferential seating either nearby the teacher or away from distracting peers, organizational supports for their desk, binders, even digital materials now. Checking in with the student for understanding after giving instructions. And making sure they're getting started on a task. So they're not, we understand they heard what they're supposed to do and they're initiating the task, as those are areas of difficulty often. Reminders for the student to check their own work for mistakes or that they completed it. So those are some of the most basic accommodations that could be on a 504 plan. The next level up that some kids absolutely need and others would benefit from, but are not often done, is to have an individualized behavior intervention plan, or a BIP, sometimes it's called. And this is really designed to promote positive behavior and to define for the child the behavior that we want them to display in the classroom, rather than punishing or reprimanding a child for displaying inappropriate behavior, which is often what can happen for children with ADHD in the classroom. So using a behavior intervention plan, it includes target behaviors that the child should focus on trying to display in school. And it includes immediate feedback or praise, even stickers or small rewards that they can get when that behavior is displayed. But as I mentioned, these are often harder to implement because teachers have limited resources. So it doesn't always happen, and they might only be put in place if the child's behavior is disruptive to the class, is how I often see it play out. But yes, I think that sort of covers some of the basic accommodations.
Thanks, Carrie. Let's shift gears a bit. Jody, one of the questions that comes up, especially at a setting like Kennedy Krieger, where we see a lot of children that have intellectual disabilities, how does ADHD present differently in the context of intellectual disability?
Yeah, one of the things we know from a number of studies is that actually ADHD occurs more often in individuals with intellectual disability than even those without intellectual disability. The difficulty becomes in how do we assess and look at the effects functionally of those symptoms when we're trying to make that diagnosis or evaluation for treatment. And so one of the key features is really looking and knowing at what developmental level is that individual functioning at. And that may be in relation to their cognitive and learning skills. It may be in relation to their adaptive or self-help skills. And so knowing at what age we see the patient functioning at makes a difference in the expectation that we're looking at for how well do they focus or attend, how distractible they are, how active are they, how much ability do they have to control their behaviors or impulses. And so that's really what studies have been looking at. How could we better differentiate some of those differences? And really, what they've shown so far is the biggest difference to look at often is with the component of the activity level and the ability to kind of sit still. Sit in the seat was one of the questions they found with the biggest variation, as well as that impulse control. So those quick to behaviors were really some of the areas they focus. And that tends to be what brings individuals with intellectual disability to be evaluated for ADHD in treatment. Often is more the behaviors surrounding hyperactivity and impulsivity, and less often concerns about attention or focus or organizational activities.
Another question, Jody, that comes up a lot is how heritable is ADHD? Is there a genetic basis? We know there's not a single gene that causes it, but is there a genetic basis for ADHD?
Right, and we do think that's the case. We know it's about 70 to 80% heritable in families. And so there's been a lot of studies, including one in 2020 that looked at a number of different loci. But what we are finding is we do think there's a polygenetic or contribution, that you could have multiple variants that set you up, not to mention the environmental factors that contribute that often can be shared or non-shared. So when you're thinking about it being heritable throughout families, we also think about those shared environmental factors that could be playing a role.
So Carrie, let's switch back to you. And I think as I'm looking at the time, I want to get to, we have a lot of questions lining up, but let's talk about how, as a parent, you can explain ADHD to your child. But what some guidance around that conversation?
Yeah, I love when parents ask me this, and sometimes I get to help them in that conversation through our assessment clinic, which is always interesting because every child's so different and how they take that in. So I think it's complicated in many ways because the term ADHD is confusing, as children with ADHD actually can pay attention to some things. It's not that they have an attention deficit, that they're unable to pay attention to all things, and they might not have any hyperactivity. So I find that it's more accurate and easier to understand this when we explain it as difficulties with self-regulation or self-control of attention, behavior, and sometimes even of emotions, which can cause significant challenges in certain environments. And typically we know for our kids with ADHD, this is in the school environment. We also know that children with ADHD have their own profile of strengths, which are sometimes more commonly in pop culture now, they're referred to as superpowers. Might include hyperfocus, creativity, passion, enthusiasm, empathy, humor, for example. And I always ask my patients and their parents about their strengths so we can highlight those. But I think it's helpful to present the whole picture to a child rather than simplifying this to, you have trouble with attention, because it's definitely more than that. Instead, it's helpful to think about how ADHD involves a pattern of strengths and challenges that makes some environments and activities easier to navigate and others much more challenging. So thinking about for your child what their ADHD superpowers are that might make school hard, for example, but allow them to shine in other settings. It's helpful sometimes to start this discussion with a problem that your child has said they struggle with. So for example, if they say they're bored and distracted at school, you can let them know that you learned some things about that might help us understand why they feel that way at school, and see if they want to understand more about that. And then you can discuss the strengths in the way their brain works, such as focusing intensely on things that they enjoy, but it's also harder for them to focus on something they don't enjoy. And to let them know there's a name for this way that your brain works. It's called ADHD. Having a name for it really helps us understand how best to support the child's growth and development. And really, by defining ADHD based on your child's experience and not as a disorder, it might be easier for them to understand it, and might empower them to be an active participant in their intervention plan. And lastly, something I find a lot of kids respond to is to let them know that they're not alone, that many other individuals share their ADHD sort of profile, although they all might look a little different. Sometimes talking about successful, famous actors or athletes like Simone Biles, Michael Phelps, or even other children or family members could be also helpful for them.
Well, I should tell our audience that we have an enormous number of really excellent questions. So what I'm going to do my best to sort of curate them. There's a lot of themes And so you may not hear your precise question because they sort of overlap with others. I'll do my best here, and I'll do my best to direct the questions to my colleagues, but chime in if you've got some additional comment to make. And I'll also say that we will pull together a number of resources that when we communicate with you all after the webinar, we'll attach to it links to resources, local resources, support groups, information such as vetted by my exceptional colleagues here to be useful for you after this event. So let's get started. Again, many great questions. Where do we dive in? So one of the questions has to do a particular question around chronic pain from a co-occurring condition, but chronic pain, can that produce the inattention and executive functions, the problems that are associated with ADHD? So for example, can another condition masquerade as ADHD? Mary, I'll ask you that one.
I think that's exactly why we do the history and the physical examination, because yes, chronic pain can absolutely interfere with your ability to focus and to organize and not be distracted by pain itself. So I think, we've seen it in children who have not chronic pain, but chronic conditions like reflux, in the classroom is really distracting. So the quick answer is yes. Chronic pain can definitely make you compromised in your attention and your focus.
Another
And-
question.
Yeah.
Go ahead.
Yeah, I would add that, any before we make a diagnosis as part of the diagnostic process, we have to rule out any medical problem, including pain or other chronic illnesses, or even sleep disorders, before we say the child has ADHD.
Mhm.
So Raj, this next one's for you. I've noticed, the question is, I've noticed that my child with ADHD is more aggressive as an emerging adult, much more so than when she was younger. Is this typical?
It's hard to generalize. Like I said, the ADHD symptoms tend to improve as the child grows older, but by teenage years, sometimes there might be other um, conditions that may begin to appear, such as anxiety disorders or mood disorders, and they can certainly contribute to some of the behavioral challenges. So, but certainly, ADHD, if it's severe and if there is severe impulsivity and there are challenges with emotional regulation, then they may be related to ADHD. But I would also think about what else might be going on in your child's life, such as stressors or academic stress or stress at home.
Here's a question I think for Jody. It's around nutrition. Is there any merit supporting the idea that ADHD is nutritionally driven? Is there any evidence basis with respect to diet or nutritional supplements for ADHD?
Yeah, I think the first part of that question goes after what we've kind of been talking about in our initial evaluation, right? Of making sure we're not missing something medically. So certainly in a case where there are other medical conditions going on and there may be really significant vitamin deficiencies or things, certainly that can present with various learning difficulties and attention, can contribute if you're excessively drowsy due to something going on dietary, then certainly that could cause more difficulties with behavior as well and emotion regulation. But looking towards actually optimizing a good diet, routine meals, not having fluctuation in your blood sugar and those sort of things is certainly important and one of the lifestyle modifications that we talk about for individuals. But for sole recommendations of a treatment for ADHD itself, there has been some data looking at various vitamin supplements, and none have shown great data consistently across that they're recommended first-line treatments for ADHD.
Carrie, this is for you, and I'm going to tap into your expertise as a neuroimaging investigator, clinician scientist, as well as a clinician overall. So it's about diagnostic imaging, advanced diagnostic imaging. Is there any value in determining autism versus ADHD using those approaches, or are we talking about strictly clinical diagnoses?
Yeah, a lot of parents come in for, an assessment and they're asking, well, are you going to do a brain scan? Will you be scanning my child to see what's going on, what's causing this? And we've been studying this for decades now to figure out can we diagnose ADHD with a brain scan? How can we use neuroimaging data to inform our diagnosis? And I think, again, this is a behaviorally defined condition. This is about behavioral symptoms that are expressed. Mapping those behaviors onto some of our brain measures that we can get from neuroimaging is really challenging because behavior is so complex. And also ADHD is highly heterogeneous. Children with ADHD, I mean, there's 18 possible symptoms that could be expressed. You can have a child with 6 inattentive symptoms or all 18 inattentive, hyperactive, impulsive symptoms. So when you think about grouping children with ADHD and to identify a brain feature of that diagnosis, I think we're learning that's less and less likely, and there's more value in using neuroimaging to understand maybe neurotypes or biotypes, like subtypes of ADHD. So children with this diagnosis, there might be different subgroups that have a certain sort of condition or brain sort of metric that we're using that relates to behavioral expression in a certain way. And also brain imaging is very expensive. So if we can use our clinical tools and our good diagnostic interviewing to make that diagnosis, then we really have to think long and hard if a $700 brain scan is necessarily worth it. But there's certainly value in neuroimaging. We're still trying to understand how that helps us understand the etiology of ADHD and possibly response to different treatments. So more to be done on that front. But in terms of using it for diagnosis or differential diagnosis, we're not seeing much promise there at this point.
So Carrie, this is a related question, and it's actually a complex one. I think I'll ask Mary to chime in as well. And it's referencing this recent article in the New York Times from a couple of weeks ago that basically critiqued the literature using neuroimaging, for example, to differentiate brains with and without ADHD, that it doesn't do so well in non-replicability in studies, was the point of the article, as well as criticism of the limitations that the pharmacological interventions that we have, stimulants, et cetera, in improving behavior per the article. So this was I think one of the most emailed links to an article I've seen recently. And I'm wondering how you think about how well those criticisms jive with your understanding of the literature around imaging, and Mary, perhaps take on the question about medications.
Yes, for the literature and imaging, it's true. There's a replication, a reproducibility sort of crisis in neuroimaging that has gotten a lot of discussion and attention. And I think it does still relate to that point that I just sort of raised about this being a really heterogeneous condition and also a behaviorally defined disorder. That I think you can have a sample of children with ADHD that is not overlapping in many other ways as another sample from another lab who's using those same brain measures, but they just happen to be sampling children with ADHD that have a different combination of symptoms. Maybe tend to have more of the emotion regulation difficulties that you didn't see in another small laboratory sample. So we are trying to increase our sample sizes in these studies with neuroimaging measures to better represent broader ADHD population so we can generalize. But also thinking about how we really need to be maybe improving our behavioral phenotyping too. So sometimes the way that researchers are studying ADHD, they're not using exactly the same diagnostic criteria or the same instruments. So I think there is work to be done in terms of research and having consistency in their behavioral phenotyping to map that better onto the neuroimaging sort of biomarkers. So this, as we become aware of the difficulties with replication, I think discussions are happening on that front as well.
Mary?
Yeah, I think I'm going to answer similarly with the medication issue, right? There's lots of different medications. There's lots of different doses of medications. There's lots of different combinations of medications. And I don't think we've learned much really yet about whether we can predict that by any other test measure, how is a child's going to do. And I think our experience, and I would look for nods across the group here, but I think our experience tells us that one of the best measures of what medication might be effective is what was effective in other family members of people who are treated for ADHD. So.
Yeah, and I will add to that, Mary. I think part of that's where I see the value in neuroimaging too. So maybe if we identify these bio or neurotypes of children with ADHD who respond better to medication, maybe a brain scan would be valuable in predicting that response to medication, right? So that's, I think the response to intervention as a subtype of ADHD could be really valuable.
Excellent points. This is a question, I think, for Raj, but others please chime in as you see fit. So the question is, I've heard about the suggestion to take medication breaks to avoid tolerance development, like on the weekends or over the summer. Is there any real evidence that taking those breaks has a benefit? And a related question around this is regarding stimulants. Is there an association with addiction? The question comes from somebody who's worried because there's a family history of, sounds like substance use disorder. So risks of stimulants, tolerance, addiction, the value of breaks. What would you say, Raj?
So that's a great question. Frequently, parents do ask about drug holidays and should my child take a break over the summer or on the weekends? And the answer is it depends. And frequently I look at what type of ADHD symptoms the child has. So if a child has pretty significant hyperactivity and impulsivity, or they have severe emotional dysregulation, etc., in that situation, I wouldn't recommend that they take a break on the weekends. On the other hand, if the child has predominantly inattentive type of symptoms, where they have mostly inattention and the symptoms manifest mainly at school, in that situation, I may say, or in addition to that, there are concerns about, for example, lowering of appetite and weight is being affected. In that situation, I may say that, okay, let's take a break on the weekends so that the child is able to catch up, on the food intake and their weight improves. Similarly, during summertime, many children, they are attending summer camps, etc. So even for participation, sometimes in those kinds of fun activities, one requires the focus and impulse control and the ability to regulate their emotions, etc. So in those situations, kids with more of those kinds of problems, I wouldn't recommend taking a break during the summers. But some parents do prefer to take those breaks, and frequently we end up restarting the medications over the summertime because there's a problem at a summer camp, or when they're in Florida going, at a theme park or something. As far as developing tolerance, I don't think there is evidence that one develops tolerance to these medications. What happens is that children are undergoing development, and as they develop, their metabolism is changing. So sometimes the dose of the medication has to be adjusted because of that. So if your child is going through a growth spurt, in those situations, the dose that had been effective before, that may not be as effective. In that situation, the dose may have to be tweaked. The other concern about substance use, what studies have actually shown is that frequently, children are, especially teenagers, they are vulnerable to developing substance abuse disorders because if they are not treated. And most of the studies, most of the literature has shown that you need to treat ADHD symptoms because it's the impulsive decision making that occurs. The teenagers may be trying to, get into a peer group, and because of the impulsivity, because of lack of self-control, they may get into a group where they are exposed to substances. So I would say that ADHD should be treated. That will actually prevent substance use disorders.
Yeah. Yeah, excellent points, Raj. Thank you. Any other comments for that? Those are great questions. Any comments?
The one thing I would add, Brad, to that is when we're thinking about those holidays, like Raj said, over summer or on the weekends for extracurricular activities, whether it be sports or clubs, STEM clubs, or those kind of things, we really want, if those symptoms or emotion regulation is causing difficulties for that individual to interact and participate in those activities, we really want them to be as successful as possible. Because one of the things that we really work with our families is really trying to push, as Carrie mentioned, their strengths as well, and building their self-confidence in activities that they really are strong in and enjoy. Is really building that self-confidence to move forward and participate in other activities that may be more difficult in the future for them. So I think it's just as important to think about their ability to participate in those activities as it is the focus we put on school academics at times.
Agreed fully. I often would make that recommendation on the ball field and at the dinner table. In other settings, it's important to be engaged in those learning opportunities that are not limited to the school setting. Interesting question about, I think it gets at the association or dissociation between intelligence and ADHD. This is a question that a child received a school evaluation that showed ADHD and a very high IQ, over 3 standard deviations above the mean. Is this a common situation, and how do we think about it? For example, this child in the resource room is typically bored. His academics are 3 years above his grade level in several areas. How do you think about this, and what should we do about it? So I'm going to ask Jody to take this on, but I think really each of you could have comments on that situation.
I think that specific example you're giving, not knowing the exact test results, right, that were consistent with findings for ADHD. But I think focusing on, as we've kind of discussed throughout tonight, is we see ADHD across individuals with all sorts of varying developmental abilities, cognitive abilities, right, weaknesses and strengths. And so I wouldn't say it's a common thing that we see. It's always associated with high IQ, right? It's just as common. We can see it, as I mentioned, with intellectual disability versus those with an average range IQ. What I do think is important in those cases, it's that, and it's just as important in any case that we're evaluating a child or an individual for ADHD, is that we're looking at all those other things that can affect those same symptoms or behaviors that we're looking into, and making sure that appropriate accommodations or assistance were provided for those. And in this specific case, if the difficulties were really primarily focused on attention and distractibility, were we really providing that individual with work and challenges that were appropriate for their level? Or the symptoms we're seeing solely related to, I'm bored and these are not within my level of ability? But certainly it's comparing, or have we provided those, and have we really made sure that those environmental factors are appropriately offered to an individual, and are we still having difficulty with function related to ADHD symptoms despite those things?
Right. And
I'd like to second that and just comment that anytime I think that there's a mismatch between the demands that are placed on the child and the child's ability to tend to those demands, you're going to see some kind of reaction. And that is the environment child capacity mismatch is something we have to pay attention to all the time.
right. And I'll just comment on the boredom issue, that boredom is frequently seen in ADHD, so it may be a symptom of ADHD. But at the same time, if a child if they are in a classroom, or they have a curriculum that is below their capacities, or they've already mastered that, then that itself can lead to boredom. So it may not be related to ADHD; it may be related to the mismatch that Mary's talking about. And so in that situation, they may need to be challenged more, and may need a grade higher level curriculum to keep them stimulated, because that's one of the challenges in ADHD, that how to keep the child stimulated at their functional level.
Harry, I think this is a great question for you. So we talked about accommodations at school and at home, but to what extent do those accommodations counter the objective of strengthening a child's skills in executive functioning? How do you balance providing accommodations versus working on building those skills?
Yes, I hear this from parents when I say, okay, well, they're having a hard time paying attention because this child's sitting next to them. We just need to put them by the teacher and take them out of that situation, avoid that distraction. How are we going to build those skills? So both things really need to be happening, because we don't want to compromise their ability to learn in school or to function with peers and to build relationships. But also need to be building those skills, right? So at the same time, especially when we're working with our adolescents, for example, the accommodations can be in place in the classroom, but they would also be working with an executive function coach, for example, to learn how to organize and manage their time, and even to build the skills that they need to resist distractions. A big one that I hear about is their cell phone in class, or that they have they're doing work on their computer, but they're going on other websites. So it should be it's not always the teachers who are taking away those access to YouTube when they could be sitting in class, for example. But if that child's also seeing a therapist or an EF coach, then they could be teaching them about how to block sites so they're not tempted to do those things in class. So I think it's a combination of building the skills through therapy, through everyday practice and life. So with younger children, it's giving the instruction for the multi-step activity they need to complete and praising them as they do it, so they're building the skill, but also not giving them so many instructions in class that they can't complete their work, right? So I think they're happening in tandem, because we don't want the child to suffer because they haven't built those skills yet. And they might need fewer accommodations as those skills continue to develop through supports and consistent sort of therapeutic instruction from their parents, who are basically their at-home therapists, once they learn these behavior management strategies, and the teacher also giving them specific behaviors to target and feedback about how they're doing with reaching those behavioral goals.
I think we have time for two more quick questions. Jody, they're both kind of neurologic in nature. I'll direct them to you. Others certainly chime in. But two brief questions. One is, is there any kind of a relationship between ADHD and other neurologic conditions like epilepsy? Is there a brain-based relationship between ADHD and epilepsy, for example?
Yeah, so we certainly know that there are relationships between those, and that our individuals, if you take epilepsy, for example, do have higher rates of having various learning difficulties as well as ADHD. And so when we think of the neurocircuitry, right, and what's involved, we do know there, even in individuals with a disorder such as epilepsy that may not meet an ADHD diagnosis, there's certain difficulties within executive functioning. And so some of the things like working memory and cognitive flexibility can be more difficult. And so knowing those, we think about some of the way our neurotransmitters and pathways that our pharmacologic treatments are based on, right? And so I always think of it as kind of like the picture catcher kind of model, and how we attack things. So what are the regulation of the neurotransmitters that are occurring during that time? What are kind of the receptors available at that time? And then how are those different centers able to talk to each other So how were those networks built, and how are those maybe affected and connected differently in those different scenarios?
And then the other question, Jody, is around sort of secondary ADHD. For example, in the setting of traumatic brain injury, does it matter what the cause is, whether it's sort of a primary ADHD, inherited, or secondary to something like a traumatic brain injury? Does the treatment differ? Does the approach to thinking about that patient differ?
I don't think it differs a lot, in the sense that it all starts, like Mary was describing in the beginning, that we start with a very extensive medical history, diving into kind of things, strengths and weaknesses prior to maybe that injury, as well as other medical symptoms and things that could be contributing to some of these difficulties that we're looking at for ADHD. And then the other key part is, how long have those symptoms been present? If it's something that's very acute in the setting of a traumatic brain injury, we may treat that with more kind of cognitive behavioral interventions. But if the symptoms are more prolonged, we can certainly treat those similarly with our pharmacologic treatments. And an example I think of, even that we don't always lump or consider in a traumatic brain injury, is if we think about individuals at a young age, children who have strokes or brain bleeds that cause chronic issues. And we know there's certainly much higher incidence of various learning difficulties, developmental disorders, and ADHD in those individuals. And we treat those the same as those individuals who have not necessarily had the same effect.
Well, that's all the time we have this evening. It's I wish we had more. We have so many great questions. I really appreciate the questions coming in from our audience. And I want to thank our experts and all of you for joining us tonight, for attending and for participating. We hope you found this Exploring the Brain webinar to be informative and interesting. So you'll receive an email from Kennedy Krieger shortly with links to the resources that I mentioned that are related to tonight's topics that I hope you'll find really helpful. And we hope you'll participate in future Exploring the Brain webinars. Follow Kennedy Krieger on social media. Listen to the Your Child's Brain monthly podcast. That's a podcast produced with assistance from WYPR and Baltimore Public Media. You can pick it up at kennedykrieger.org/YCB on Kennedy Krieger's YouTube channel or wherever you get your podcasts. For more information about Kennedy Krieger Institute and how you can support our work, please visit our website at kennedykrieger.org. I want to again thank our panelists for sharing their expertise with us this evening. And again, all of you for joining us for Exploring the Brain. Thank you and have a wonderful evening.